Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Welcome to On the Go with CAO. This segment entails diseases of the spine, management, treatment, which would consist of non-operative and operative care. We are covering different aspects of orthopedics. We are a group of physicians around the Washington, Virginia, Maryland area who have gathered together to provide a unique blend of care for our patients. Today on our panel, we have three of our spine specialists throughout the Washington, D.C. metropolitan Baltimore area. So the way we want to start off with part one is introducing diseases of the spine, common causes, atypical causes, and when to actually go and visit a physician.
So understanding spine or low back pain or neck pain is really good to have a background on what causes pain in general. So you have the inflammatory pathway where anything that causes inflammation, it can be an injury, a fall, and so forth, or you have your neurogenic pathway where you may have neuromodulators in your back that are exacerbating pain. The most common causes for back pain are in the former, which I mentioned. Essentially, you have your muscular causes or your myofascial causes, essentially involving the soft tissues of the spine. You have degenerative causes, which we oftentimes hear about, DDD or degenerative disc disease. Falls within the umbrella of degenerative or arthritic back pain. And then you have some atypical causes, which we'll get into later, such as tumors, infections, and so forth, which are less common. But that's the general category for what causes most neck or back pain in adults.
Most common injury that I typically see would be a muscular ligamentous type injury to the back, lifting something heavy, shoveling the snow the wrong way, packing, moving, relocating, things like that. Then you got your older population that may have more of an arthritis issue. You have degenerative discs, as just mentioned, which sometimes can happen to younger people or older people. Those are typically the most common ones. You do have some of the less common ones, which would be a fracture, which is a broken bone, or a tumor, or an infection. And then, of course, you have the most thing you hear a lot about. It's called a slip disc, which is a herniated disc, which is actually very, very common and most of the time can be treated in a non-operative fashion, but not always, but most of the time.
And it's kind of interesting to hear about the different ways you can think about back pain. You can think about it in sort of the science of it, the physiology, what's the process, or sort of like where Emeka got to at the end with the structural. So for me, he's a lot smarter than me, I guess, but I just go with just the structure. And so is it a muscle that's hurting you? Is it a facet joint that's hurting you? Or is it another joint lower down in the spine? And you can do the same thing in the neck if it's muscle-mediated pain, joint pain, and then break it down into various causes depending on sort of the patient's story. So a lot of people have arthritis in their back and they get a little older and they start to lean forward, and that puts a strain on their low back, and their back the muscles at the base of their back become sort of like a crane to hold them up, and that can cause pain and fatigue. They can have an injury where they fall and they hurt something. Or sometimes people come into the office and they have new low back or buttock pain from riding their new stationary bike, and they haven't built up enough gluteal strength to stand up and ride for long. And so strengthening can be a way of allowing you to cope so you can function the way you want to. Or they can be older and they can have arthritis and it hurts for them to lay on their back or to stand to do dishes or try to put the dishes in the dishwasher. And that could be more facet-mediated pain or joint pain in the low back. And then also there are people who just have a lot of stress in their life and they feel their stress as back pain.
It's very interesting that you put it that way, because the other day we had the foot and ankle session. We were discussing about assessing patients, and it's not cookie cutter. It's not cookie cutter. Everybody comes in and you to see each person individually and take an intake history of that first 3 to 5 minutes. You learn a lot about who you're talking to and what they do and what their aspirations and what they want to do. So when they come in the room, I mean, I'm gonna segue a little bit and ask you guys how you assess the person when they come in a room. I think a lot of patients don't realize that when you walk in the room and when you see them, even though you may not be asking them questions, your assessment of who they are is happening visually as well as verbally. So how do you guys go about doing that? And someone go, I got low back pain, middle age or whatever it is, or young guy or older.
So usually when someone comes in with back pain, I think the first thing you do is you try to make sure it's nothing dangerous. And so there's a whole bunch of screening questions, but you want to know how bad the pain is. You got to make sure you ask them if they're having certain things like fevers or chills or night sweats or unexplained weight loss to rule out something dangerous like a cancer. A lot of times people come in, they'll be 50 and someone in their family just passive cancer and they have back pain, or someone got diagnosed with cancer, they have back pain. That's what they're there for you to make sure, tell them they don't have back pain from their cancer. You ask them if they had a trauma. And once you've ruled out a lot of those things, most of the things that cause back pain are self-limiting, and you sort of just try to listen to their story and figure out what it is. The other thing you make sure they don't have is a neurologic deficit. So, the back has all the nerves there. So if there's some kind of issue that's causing a change to the structural integrity of the spine, it could affect the nerves. So you just make sure that their nerves are working right. And then you move forward and usually just give them some anti-inflammatory medication and send them to therapy.
I'm glad you mentioned that. You were talking about neurologic manifestations and stuff like that. That's part of our clinical examination. So there are 2 different ways of assessing people with nerve injuries. There's radiculopathy and there's myelopathic. So I'll throw this to Phil. Can you explain to people the difference between the 2 and the urgency of one versus the other?
I just wanted to cover one thing I forgot to mention earlier. There's we talk about the common causes of back pain, and what I didn't think about, but really is a really common cause that's getting more and more play these days in press, is the sacroiliac joint or the SI joint. Is a frequent cause of pain, and it's in some studies it may be up to 40% of all what you call back pain. So that's another thing that we.
Since COVID, have you seen more of it?
Yeah, well, we see a lot. We're seeing a lot of stuff in terms of back pain in kids too. They've been home doing their homework, laying on the sofa, curled up, all kind of crazy positions, and adults too. So we're seeing a lot of that back and neck pain. But going back to your question about the myelopathic, that's really not a lumbar back issue. You're talking about the cervical or thoracic spine. And myelopathic is a more serious condition when you have compression of the cord and you're affecting the upper motor neuron, which are the cells of the spinal cord. And that's a much more serious problem. That could be a permanent problem. That could be irreversible at times, and could cause significant difficulty in walking as well. So that's a more serious condition, typically related to the cervical spine most of the time. Radiculopathy is your typical thing is you might have heard the term sciatica, a pinched nerve down your leg. That's a radiculopathy, a pinched nerve down your leg. Or you get a radiculopathy, a pinched nerve down your arm. But when the spinal cord is affected, you hear the term myelopathy more often.
So timing, so I'll throw that down to you, Emeka. Timing is sort of like that. So myelopathy versus radiculopathy, the timing of intervention, how would you explain that to the patient population?
Yeah, to segue to that, I would, just to elaborate on what both Ayo and Dr. Schneider have already mentioned. The first thing that we obtain from the surgeon standpoint is really receiving this patient's story. Their story can give you probably 80% of the picture that you need to see, more so than diagnostic imaging, and can honestly steer you in the direction of what they need. The question in terms of the seriousness of a patient's symptoms, is that what you're saying? And at which point do you need to be more concerned, is really going to come down to the Again, the story that they tell you, or is it someone that's radiculopathic, as he mentioned? Do they just have isolated nerve root symptoms such as sciatica or radiating pain down the leg or down the arm? Or are they experiencing more serious symptoms such as loss of control of their bowel or their bladder, or their ability to walk? They're not just weak in the legs, they may completely be imbalanced. And those are some of the red flags. In addition to their dexterity, are they having an issue with controlling their with their dexterity, with their writing, with their manuscript, or not being able to button a shirt with coordination? Those are the things that help us distinguish what's very serious and someone may need more of an urgent imaging versus putting someone through more of the conservative measures. Just to give some sense of a way to gauge those things for patients, because a lot of patients are very worried about what they have. In all honesty, you will know if you're not able to walk, if your balance is poor, you will know. And if it's going on for a long period of time, and if it's getting worse, you will know. Same thing with on the other side of the spectrum. If your symptoms are more isolated, I have this shooting pain or numbness going down one leg. That's very different. That's not as dangerous, not as serious as some of the things we just mentioned previously. So we use that information to gauge how urgent, how serious someone's symptoms are, and what we should do next.
I hope that helps people distinguish the difference between what is urgent with some back pain and what is important. It may not be as emergent, but something that, maybe you don't have to rush in or right away, but when you have those bowel bladder symptoms and loss of dexterity and your gait is really off, that's something to be really concerned about. Thank you very much for explaining that. So that sort of like segues a little bit into when you should go and see a physician or a spine specialist or even orthopedic surgeon or even your primary care doctor about your back pain based upon your symptoms. But would we all agree that pretty much in large, that the majority of people do not have those catastrophic symptoms, those symptoms we talked about that need emergent, unless you're in an arena of, say, a trauma center?
Yeah, absolutely, absolutely. I would say, most of us know on the medical standpoint that the second most common cause for patients to see a physician are for neck or low back pain, and the majority of those things are muscular, myofascial, or due to degenerative conditions, which we just communicated. Times that you should be more concerned, or if your symptoms are progressively worsening or intensifying over a period of time, not just a few days, but over weeks. If you start to notice any what we consider neurologic symptoms that your primary doctor or your specialist may ask you about, such as weakness or numbness, and then definitely the red flags which we mentioned, the loss of control of your hands, the loss of control of your bowel or your bladder, not knowing when you have to go to the restroom, as well as the issues with your gait, losing coordination in your balance and so forth.
I see so many patients that come in to see me that have been seen by other doctors for hip or shoulder problems or something like that, and really it's maybe their spine or vice versa, and so you have to be very careful when you talk to the patient that you try to tease out the information. They say their hip, but it's not really their hip. They're talking about their buttock area, and sometimes they kind of go down the wrong path. You have to be really careful and talk to them and find out, is it really their back, or is it their hip, or is it really their neck, or is it their shoulder, or maybe and sometimes it could be both.
Yeah, it could be both.
Yeah, it could be both. And so that's part of the whole, I guess, the art of the science of medicine to try to figure all that out, because you can get misled sometimes.
A lot of times people will start losing function and they'll say it's because they're getting old. And a lot of times they don't understand that arthritic changes in the spine, they happen the same like everywhere else in the body, but the problem is that the spine houses your nerves. And so those bone spurs, those discs, they can push on structures that you need for your brain to communicate with your arms and your legs, and then you get loss of coordination. So a lot of times people will fall and break their hip, but no one will ask them why they fell or what their functional level was before. And, you know, in our training, the basic thing was like, well, what was their walking ability before they fell? Were they using a cane? Because if they're using a cane and you fix their hip, after it's broken, they're going to move to a walker probably. But no one's asking, well, why did you fall? Are you off balance? No one's doing, one test that we use when we evaluate patients to see if their balance is okay is we'll make them do like a sobriety test walk. And if they can't do it, it clues us into that there's something wrong with their balance. And so, or I've had patients who are in their 50s and they fell and they have some rib fractures, and they come into the office and they're like, I'm here to follow up for transverse process fractures, which are like the ribs of the vertebrae in your low back. And I'm here for a follow-up of spine fracture. Like, that's not a fracture. And but you asked why did you fall? I was like, yeah, I just don't have good balance. I go down the stairs and I feel like I'm drunk. I was like, okay, let's get a neck MRI. And you see their spinal cord has pressure on it, and then you talk to them some more and they're telling you that, yeah, you know, I used to be a scratch golfer, but I stopped because I lost my coordination. It hurts to hit the ball. Or I used to play guitar, but I can't anymore because my fingers are messed up. And then it's amazing, you do a surgery for someone like that to try to get them to not get worse classically, but they actually get better when you take the pressure off the spinal cord. And they're like, yeah, I'm back to playing piano. Yeah, I'm back to playing guitar. And that's what we love as orthopedic surgeons, helping people get their function back.
A couple things I'm going to throw out there. One is the quality of life. We're finding, I think, I don't know if you all agree, that our patient population, especially those between the ages of 40 and 70, really do not want to accept being sedentary or dialing back. Like, no, I'm not dialing back. I still want to be active. I may not be 20, but it doesn't mean that I have to say I have to hang up my shoes and I can't do anything. I still want to be active and do these things. And they're finding it difficult because of problems with back pain, neck pain, and they can't function as well. So in your
I would say it may be even older than 70.
Yeah.
Some of my patients, they want to be back, you know, in the 80s. They're still working when they're 70, a lot of folks. So,
yeah, so they really want to be. What would you suggest to our audience here? Things they can do that they can, you know, we like seeing you. We do like seeing patients, but there's a lot of times you can avoid us by doing some things at home on your own to keep up with yourself. Because as each decade goes on, your muscle conditioning goes down. The strength of it, your fibers change, the ligaments change, the makeup, the biomechanical and biochemical makeup of the structures in your body changes, and it's unavoidable. We can't help it. It just happens. So you have to do something at home or go to a gym or whatever it may be to avoid such a rapid decline in function. What do you guys suggest that people do?
When I'm presented with that sort of question and someone in, you know, middle-aged, older adult that feels like they're losing their functional capacity is essentially what we call it. They feel like they have pain when they do try to move, or the other way around, they want to maintain their level of function and being able to run, exercise, bike, and so forth. I try to educate them on on two sides of things. There's some things that we can control when in the human body, and some things that we can't control. Surgeons, patients, no one can control the aging of the human body. Your discs are going to wear down over time. Just as I tell patients all the time, just as your skin wrinkles over time, the inside of your body also wears down over time. But for the most part, it does not have to be detrimental. If you try to maintain the aspect of your body that you can control, such as your muscles, your joint health, your endurance, your cardiovascular status, those things you are in control of. And the only way to do that is by the persistent exercising, persistent mobility, not falling victim to what your body may be telling you to sit on the couch all day or to lay around all day, even though you're in pain. But we know that doing that isn't sitting down, being sedentary for most of the day, only perpetuates those things that you're trying to avoid, such as the low back pain or the neck pain or the stiffness. We know that both practically and scientifically, that if you don't move a joint, if you don't move your knee for a period of time, a week, 2 weeks, it's going to get stiff and it's going to hurt way more than it did before. So your goal is to control the things that you can control, which is the muscle tone and the soft tissues around the spine.
I mean, we get this question, every single day, multiple times, all day long. And what I tell people is even though maybe when you were younger, you exercised a lot, and now that you're older, you don't do it as much. Exercise may be more important as you age than when you're younger. When you're younger, you kind of bounce back quickly. As you get older, exercise is actually more important. And it also goes to the basic tenets of health, Don't smoke, eat healthy, don't get fat, stay in good shape. And those are all real important as you get older. See your primary care physician for a physical exam. Make sure other parts of your body are working right, because your spine's just one part. And then also exercise, stretch, and get some cardio every single day or 5 days a week if you can. It's also really important, especially as you get older.
And that's pretty much what I convey to people as well. Particularly I tell people you need to work on the muscles of go, not the muscles of show. I think a lot of guys in their 20s, the muscles of shows, having these big bulky muscles and stuff like that. I mean, that's nice when you're in your 20s, but as you get to 40 and 50 and you're carrying that weight, that doesn't feel too good on the joints. It really doesn't. So you really want to watch your weight, as Phil was saying. You really want to work with your range of motion of the joints. That's very important, having full range of motion versus a restricted range of motion in doing the aerobic cardiovascular activities. And it could be various things. You could pick out whatever you want, but it should be fun. It should be fun. It shouldn't be something that's strenuous.
The only thing I would add to what we've discussed so far is for patients to kind of understand where they are at the moment and look forward, not look back. In terms of being in pain, feeling like you can't go out and walk, or you can't do the things that you want to do, having an understanding of you're starting here and your plan is to move forward incrementally. So when a physician tells you, okay, you should put off some weight, they shouldn't be expecting you to put off 50 pounds in the next week or by the next visit. It starts 1 pound at a time. Same thing with mobility. If today you can only walk 10 feet, your goal is to walk 10 feet for a week, and then tell yourself the next week you're going to walk 11 feet. And that's actually how you get to the place that you want to be.
Orthopedics, before we started doing surgery, mostly just gave people braces. And so we're about mechanics, and a lot of the things that bother people are mechanical. And so building up strength is a way of coping to offset mechanical breakdown so you feel better. So for example, like I was saying before, if your back hurts because your spine has collapsed and so now you're stuck forward and you have to work really hard to be upright to do anything, the only thing you can do to offset is that to be stronger in your lower back, right? If the joints in your low back hurt you and you can't rest on them to stand up, the only thing you can do is strengthen your core so that you can kind of pull yourself forward so you're not loading those joints as much in the low back. So all you can do is work. And then with the weight, it's mechanical. So if something hurts because there's a load that your body's not liking, then trying to decrease that load is a way of you trying to make yourself better. As much as I want people to be better and I want them to function, and I want them to thrive, people have to want that for themselves. And if they want that for themselves and mechanical load can be contributing to their pain, then they'll work at it.
You're hinting towards balance. You're hinting towards balance, not only just the aerobic part, but also the strengthening part, because you have to strengthen, and muscles respond to stress. So you have to strengthen as well as the core and stuff. It just can't be all aerobic running and stuff like that. You have to do some strength, some core work to get rid of these problems.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.